Michi Shinohara. I am a dermatologist and dermatopathologist at the University of Washington and at the Fred Hutchinson Cancer Center in Seattle, Washington. Lymphoma, I like to explain to my patients, is a type of a cancer of the white blood cells. Cutaneous T-cell lymphoma is a variant of lymphoma that's involving the skin primarily. Lymphoma as a cancer of the white blood cells could involve any compartment or area of the body where we have white blood cells. And it turns out that the skin is one of the areas that's richest in white blood cells. There's actually 9 times more T cells in our skin compared to the rest of our body combined, much more than in the blood. And it's because our skin's main purpose is, as an immune organ, it kind of keeps the outside in and keeps the insides out. But just as with anywhere else, when there's abnormal growth, you can get cancers. And so actually in the skin, because there's so many T cells, cutaneous T-cell lymphoma is the most common type of lymphoma, which is different than internal or systemic lymphomas, where B-cell lymphomas are much more common. CTCL is in general an uncommon disease. I tell my patients, you're 1 in a million, but it's more kind of 6 to 8 out of a million for cutaneous T-cell lymphoma, all the different variants. And the most common variant is mycosis fungoides, which takes up about half of those 8 cases per million per year. That's in the US. It can take years to get a diagnosis, sometimes up to a decade or more. And it requires multiple things for diagnosis. But key is that somebody has to think about it first. They have to be suspicious of it. And skin biopsy is really the kind of slam dunk for making a diagnosis. But I'll comment that even with a good skin biopsy done by a great doctor, read by a great pathologist, we can still miss the diagnosis. On average, people can get 6 to 8 biopsies before they get a diagnosis, and it can be several years. So it can be really challenging just because the pathology of cutaneous T-cell lymphoma can look a lot like either eczema, psoriasis, kind of more frequent or common skin disorders. So it's very easy for us to mix them up. So everybody needs to get diagnosed accurately. And most of the time that means that they've seen a dermatologist, because dermatologists are the ones who somebody's probably going to present to if they have a chronic skin problem that's not getting better with usual therapies. So that's usually people's first stop. If people have very early disease, or what we call patch plaque disease, where they just have kind of thin eczema-like patches, they may actually just be cared for by a dermatologist and never need to see an oncologist. But certainly when patients have more advanced disease, meaning they have tumors or blood involvement or something like that, then they usually do need the care of both a dermatologist and an oncologist, often with dermatologists taking over their skin-directed care, so helping manage itching and topical treatments or external treatments, and oncologists managing internal or systemic therapies. So it's a joint venture for some patients. The main goals of treatment are really what is going to improve patients' lives. We don't try to cure cutaneous T-cell lymphoma. In the olden days, we sometimes did. People would get systemic therapy kind of early on in an attempt to cure them. And what we found out kind of quickly is that it doesn't really work. And we were making people sick without actually curing them, just because the skin is such a good reservoir, an area for the lymphoma to stay. It's very hard to completely eradicate it without knocking out the normal immune system as well. So since we're not good at doing that, we actually don't try most of the time. And that's okay, because it turns out that survival rates are quite good for most patients. The majority of people have early disease, meaning that they come in with thin patches or plaques, and they stay in early phases. They don't necessarily advance to more later stages. So if we already know that people are going to do generally well, we don't want to give them treatments that are going to make them sick. So the goals of therapy are really to make people more comfortable, to improve their quality of life. If they have itching, to manage their itching, and to reduce the disease as much as possible so that it's not, a daily thing. It's not, I tell patients, I don't want this to be the first thing you think about each day. Know that it'll be part of your life, but we don't want it to be the first thing that you think about. So for patients with early phase disease, the frontline treatments are really external. So it's going to be things like topical steroid, topical nitrogen mustard, external treatments directed at the skin, since there's only involvement in the skin. For patients with more advanced or internal disease, the first line therapy is again pretty variable. If somebody depends on whether somebody has tumors or lumps, or whether somebody has blood involvement. The good thing about cutaneous lymphoma, which is really different than other types of lymphoma, is that we can reuse treatments. So if somebody has gotten treatment with a certain agent, say topical nitrogen mustard, and they got a response, and then they stopped the treatment, and then they get their disease back again. In normal oncology world, we would say, okay, their disease has broken through that treatment. You can't use that treatment anymore. But in cutaneous lymphoma, we say, actually, if it worked before, we can use it again. And so we can recycle treatments, which gives us a lot more options. Rather than just marching up this path and kind of running out of options, we can kind of go back to things that worked before. It's also common that patients have different areas of their body that respond at different paces. And so there may not be just one treatment that works for a person's entire self. So it's pretty frequent that we will combine treatments, a little of this, a little of that, to really improve patients' quality of life. Because certainly there are some subtypes of CTCL that are curable, and some patients who have enjoyed that. But I tell people that's not a realistic expectation for most patients.